specialist at the Brain Injury Alliance of New Jersey. The Alliance is a nonprofit organization with a mission to provide education, awareness, prevention strategies, advocacy, and support for those who have been affected by brain injury. I would like to announce that we'll be hosting another webinar on December 18th on disorders of consciousness. More details about this will be coming, but you can find more information on that link on the slide as well. And also save the date. So we have our regional trainings for health and human service professionals coming up March 6th at Kessler Foundation in East Hanover, and then March 12th at Cherry Hill Library. And then lastly, save the date for the annual professional seminar, which is scheduled for May 14th, and just stay tuned for more details about those as well. So I just have a few housekeeping notes before we can begin the presentation. Attendees' microphones have been muted, so if you have any questions during today's webinar, please type them out in the Q&A box. We will get to as many questions as possible at the end of the presentation, and the webinar is being recorded and will be available for viewing on the BIANJ website. At the end of the webinar, a link for a post-webinar survey will be placed in the chat. We do value your feedback, and so you're encouraged to complete the survey. You must complete the survey in order to receive your certificate of attendance. Once you complete the survey, you will automatically receive your certificate of attendance via email. Our presenters for today are Dr. Christy Levatino and Dr. Ilana Beicher. Christy Levatino is a physical therapist at Rehabilitation Specialists since 2019, working with the brain injury population. She graduated with her doctorate in physical therapy from the University of Scranton in 2013. Christy recently presented at BIANJ's 42nd annual seminar with Ilana. Ilana Beicher earned a PhD in leadership studies with an emphasis in health professions from the University of the Cumberlands in 2024, and a Master's of Science degree in occupational therapy from Elizabethtown College in 2006. Ilana worked at Kessler Institute for Rehabilitation in West Orange from 2006 until joining Rehabilitation Specialists in October 2013. Ilana has experience in a variety of diagnoses, including spinal cord injury, joint replacements, amputees, and ultimately found her specialty in the area of brain injury. She has written and published articles, as well as presented both nationally and locally on a variety of topics related to brain injury rehabilitation. So I am pleased to welcome Dr. Christy Levatino and Dr. Ilana Beicher.
Great, thank you so much. Okay, hi everyone. My name is Ilana Beicher. Thank you for the wonderful introduction. My colleague, Christy, and I are here to talk to you guys today about the use of virtual reality in the brain injury population. You've already been introduced to us, and we have no financial or other conflicts of interest to report. Our objectives for today will be to provide a current review of the literature focused on the use of virtual reality in the brain injury population, to review the current guidelines or recommendations regarding the use of virtual reality in brain injury population, to identify gaps in the literature and any identified treatment recommendations, and to provide a case study on the use of virtual reality in long-term survivors of brain injury. So first, we're just going to watch a quick little video on virtual reality to put us all sort of in the right mindset. And the volume may not work, but you can take away from the video just by watching. So that little video is just an introduction to show you that virtual reality can take us anywhere, anytime, and it just has such far-reaching potential usages that you saw we could go anywhere from Paris to London to outer space. So lots of potential things for us to do. So now that we're oriented to that, first we'll start off by defining virtual reality. So virtual reality generally can be defined as computer-generated digital environment that can be experienced and interacted with as if the environment were real. So in that video, it would be as if we were really in those places. There's a couple different types that we'll talk about next, but in many types, there's controllers or body sensors that are translated into that virtual reality and motion tracking with interactive environments. So more specifically, virtual reality can be classified really into three separate types: immersive, semi-immersive, and non-immersive. So immersive is what you sort of see in that video on the top. So it's use of a head-mounted display where a live view changes, and it consists of various hardware like head trackers, body motion sensors, and head controllers. So in an immersive situation, someone is in a 3D environment, and via use of that head-mounted display and through controllers and the person's movements, they can basically interact with and move throughout their virtual setting. In the semi-immersive type, it's systems that use a projection like on the wall. So the person may be able to tap things and interact, but they're not fully immersed. Then the last type is non-immersive virtual reality. And that's what we think about when we think about video games and computer games. So we're sort of looking at an alternate world, but we're not really immersed into it. And so for most of today, we're going to spend talking about immersive virtual reality with the head-mounted display and having individuals really be a part of the environment that they're being immersed into. So why is virtual reality relevant to brain injury? Why should we even be bringing this up or thinking about using it as a potential treatment for individuals in this population? And through a literature review, Christy and I really broke it down into three major areas of why virtual reality can be a really great fit for the brain injury population. And there's three major areas. So neurological changes, the ability of the clinician and the clinician's role, and client-focused considerations. So in terms of neurologic changes, there's been a variety of study completed looking at this. And so the use of virtual reality can actually influence the brain's neuroplasticity because it provides intensive, repetitive, and motivating rehabilitation, providing lots of feedback. The feedback can then induce cortical reorganization and enhances experience-dependent neuroplasticity through motor learning principles, and that's relying on things like real-time feedback, attention, and implicit learning. So because they're immersed into this environment and provided with this immediate feedback, that neuroplasticity and in turn cortical reorganization can be enhanced. Virtual reality also allows for task specificity of training, as well as a variation of implementation for different motor learning strategies. And again, with that ability to provide repetition and immediate feedback, motor learning can be enhanced. Virtual reality also provides the clinician some unique opportunities. So it allows the clinicians to really modify the environment. And later, when we get into demonstrating the system that we've used, you'll see that how many options a clinician has. But, you know, we have the ability to make things more complex, speed things up, slow it down. And by doing that, we're able to really tailor the intervention specifically to the client. So essentially, the clinician is able to manipulate space, time, physical laws, other input like noise and sounds, which leads to easily repeatable, personalized, and gradable interventions. There's also specific client-focused considerations that we can make. And so I've already been referencing, but a lot of research is supporting that compliance and motivation in pediatrics through adults is really enhanced through virtual reality. Active learning is promoted because that motivation is there. And so because we can control difficulty levels, we're able to adapt things, monitor progress, and really achieve success for patients that we might not be able to do in more traditional ways. Also, because the system provides immediate feedback and clinicians can also tailor that, the client is provided with accurate feedback via a method other than just us talking to them. So things like success or not success, accuracy rates. And this can improve a level of awareness in our clients that results in improved outcomes, improved self-awareness, and improved compliance both in and outside of virtual reality. So these three areas summarize basically all promote improved client outcomes in the areas of physical, cognitive, and psychological functioning. So we'll further explore what research has supported thus far in terms of the literature review about virtual reality. So as of 2021, there's still, limited research that really focuses on the traumatic brain injury population, while some more information does exist about the acquired brain injury population. So in one study, Moraes and colleagues completed a feasibility study, which really looked at evaluating the use of virtual reality with survivors of moderate to severe brain injury. And in that study, clients were involved in 12 20-minute immersive virtual reality sessions over 4 weeks. And this was a small study of 13 males, again, all with moderate to severe brain injuries. The outcome measures they were looking at were primarily based on cognition, so things like executive functioning and memory, and they also evaluated potential negative outcomes like cyber sickness. So the results really indicated that virtual reality was tolerated well overall. And while some people did report that feeling of cyber sickness initially, no one chose to discontinue the treatment, and they reported less and less of those complaints over time. So the conclusions really indicated that virtual reality was both feasible and safe for survivors out of this study. It's also important for us to note that virtual reality has been incorporated into a magnitude of medical settings like pain management, client education, prosthetic training, phobia treatment, stroke management, traumatic brain injury. There's new research into empathy training. So the precedent has been set in a variety of other settings, as well as brain injury in some capacity, that is really worthwhile for us to research and look into using this treatment further. So in another study, Ada and colleagues completed a literature review of available literature as of 2018. So they evaluated 11 studies evaluating immersive virtual reality in clients with brain injuries. 10 of the 11 studies, of those 11 studies, 3 of them were case studies, 5 were uncontrolled experimental studies, 2 were randomized control trials, and 1 was a reliability study. So if we remove that reliability study, that leaves us with those 10 studies. And so then 10 out of the original 11 reported positive outcomes, meaning that there were improvements in the client's functioning. So specifically, they supported that concepts of repetition of skills and task-oriented activities. And, we just discussed how that could impact client motivation, neuroplasticity, and motor learning. And that overall, the virtual reality was really well tolerated and improved compliance and motivation. So they again reported some of those mild adverse effects like motion sickness, fatigue, eye discomfort, but still people generally responded well. But of all these 11 studies, it's important for us to note that really many of these were really low quality evidence in the terms and perspective of research rigor. So next, we're going to break down, cognitive and physical benefits a little bit more in detail by what benefits are seen and what the research supports. So to start with, I'm going to discuss the cognitive benefits. So specifically, studies have examined executive functions, memory, attention, and coping strategies. So in one systematic review, looking at 9 studies, which was 4 random control trials, 3 case studies, 1 prospective study, and 1 pilot study, overall results indicated that across those 9 studies, there were no adverse effects, side effects, or harmful complications in the use of virtual reality for the brain injury population. In regards to the executive functioning component you see on this slide, 5 out of 5 studies that assessed executive functioning reported significant improvement, with some fluctuations noted based upon which assessment measures they used. In terms of memory, again, 5 out of 5 studies assessing memory again reported general improvement overall, and with again some of those fluctuations noted in assessment tools. And then in terms of attention, 3 out of 4 studies reporting on attention reported significant improvements, while the final study did not. So overall, while 9 studies is not a huge number, the results of those studies are still looking pretty positive. In regards to coping strategies, the studies looked at the ability to provide repetition and feedback and the opportunity for errorless training. And the use of that training and feedback, as we already mentioned, self-awareness can improve. The theory is that there's room for improvement of coping strategies based on that improved self-awareness, as well as improved global stimulation of dual motor and cognitive tasks. So there really is sort of many opportunities for growth and addressing cognition. And in specific to that coping strategies, one study did compare brain injury survivors using a non-immersive system, and that system showed greater improvements in coping strategies compared to control groups using no virtual reality at all. So again, while limited, there is still a lot of opportunity and some, initial research that's really supporting the efficacy and use and outcomes specifically towards cognition and the use of virtual reality.
All right. So I'm going to be taking over discussing some of the research which supports the physical benefits of VR. Evidence has supported physical benefits with use of virtual reality. A few areas to note are improvements with balance and gait, walking speed, dual tasking, and improved confidence with gait. Most research supports the use of virtual reality in combination with conventional therapies. Okay, and I'm going to go over some articles that discuss and support some of the research for the physical benefits. Okay. Porras et al. Conducted a retrospective study on VR rehabilitation, analyzing the records of patients who participated with VR rehab intervention at a large rehabilitation facility. Records were analyzed to evaluate the effects of VR interventions on gait, balance, functional mobility, and dual tasking activities. Records were grouped into the following: traumatic brain injury, stroke, Parkinson's disease, multiple sclerosis, and non-neurological patients. There were a variety of VR systems used in this study. You had the Karen Base and Karen Dome. These are semi-immersive screens projected on the walls with a moving platform. And the Karen Dome is pretty much a 360-degree room with that visual stimulus of the VR. The V-Gate and C-Mill were also used, and those are also semi-immersive treadmill types of VR systems where there's either a screen on the floor or on the platform that they're on, where they have targets to interact with. Records were analyzed for 12 sessions of VR treatment pre and post testing. Each session averaged between 30 to 45 minutes, and some clients also had multiple interventions. The VR treatment consisted of intervention only, and they weren't in conjunction with conventional therapies. The study reported improvements with gait, balance, walking speed, and functional mobility. It was determined that VR is practical and suitable with clinical practice. Improved confidence was reported for balance and gait tasks. Most importantly, positive feedback was also reported by the patients who participated with VR services. Virtual reality services allowed for a personalized treatment plan. Clinical significant progress was noted for patients with traumatic brain injury and virtual rehabilitation as well. With this research, there was lack of statistical significance due to the small sample sizes in this study, along with the age deficits and various severities of injury. The research overall recommended that virtual reality services to be complemented with conventional therapies. And then Alashram et al. Conducted a systematic review of randomized controlled trials and use of virtual rehabilitation following brain injury. Sessions varied from 15 minutes to 50 minutes, 2 to 3 times weekly. A few studies complemented VR with traditional therapies as part of the treatment, while others compared VR treatment to traditional therapies. Overall, improved balance and mobility were found in both groups. There were no adverse effects noted in these studies for VR intervention in patients with brain injuries. And it was also recommended that VR be complemented with traditional therapies and that VR was not superior to traditional therapies. The research also identified that VR provided repetitive practice, motivation, and feedback, which are components of motor learning. And VR can allow for feedback to promote that awareness of results, how well the patient did. They have that opportunity to see those results visually, be rewarded for the results to further carry over those principles of motor learning. Additionally, VR allows for addressing our visual system, which is also one of the key components for balance and postural control. Okay. All right, and our research also, we identified a few risks and limitations with use of virtual reality. First, cost and accessibility of VR devices can significantly impact VR practice. There's limited availability of VR services in geographical areas, which can affect access to VR. Locations which provide VR services may not take all insurances. Therefore, this can also limit a patient's opportunity for VR services. Technology can also be a limitation as it can quickly be outdated and will need to be frequently updated to remain effective, which can also be costly at times with updates. Motion sickness, frustration, fatigue, and eye discomfort were also reported with certain VR interventions. The term cyber sickness was used to describe a set of unwanted symptoms like nausea, headaches, disorientation, balance deficits, and dizziness, also associated with VR. These side effects were most commonly reported for individuals participating with VR services using the head-mounted display. However, these reports of symptoms were very minimal throughout the research. And to ensure safety, a 1-to-1 ratio must be provided when utilizing VR interventions with patients as well. Okay, so how do we determine who would be a candidate for VR? So first, we need to conduct a thorough evaluation of the client's sensory, motor, and cognitive deficits. We need to review the prior clinical diagnoses, history of treatments, history of falls, medications, and their current level of physical activity. And that's pretty typical to what we use for any kind of treatment intervention that we provide. We need to determine the suitability of the virtual reality environment for that client. All right, we need to think about that level of immersion. Is it safe to utilize a head-mounted display for that client? Or are they more suitable for a semi-immersive experience? Can they safely stand or ambulate, or do they need a system that can accommodate them to be seated to participate with virtual reality? Intensity should also be considered, and that's going to be dependent on 2 variables. One is the client's motivation. What do they enjoy? What are their goals? Do they enjoy sports? Are they competitive? Do they enjoy music or art? That's going to play a big major role in the client wanting to participate in VR. And another thing is, how do we progress the client within the system? How do we challenge that client in that setting, task variation, provide that external feedback, and personalize it to make the VR patient-centered? We also need to determine the client's satisfaction with the VR at the end of the treatment. Did they enjoy it? Did they feel okay? Was there any concerns with their treatment? And also, most importantly, professional specialization and familiarity with the virtual reality is key to further determine appropriateness for VR intervention. Make sure we know our contraindications and precautions specific to our equipment so that we keep our patients safe as well. All right, and recommendations for use of VR. Limited research exists that provides guidelines specific for designing and implementing virtual reality interventions specific to TBI. There's low-level evidence is present regarding ABI and virtual reality. However, the recommendations for utilizing VR overall include engaging the users, considering the participant, reviewing their appropriateness for participation with VR, looking at their history, making sure there's no contraindications. Technology factors are also important to consider. Being familiar with the equipment, how to safely utilize it. We want to also recognize facilitators or barriers to VR services that may not be appropriate for that client to use them. Incorporating and making sure we're incorporating our rehabilitation principles, strategies and motor learning, real-time activity, utilizing that feedback of performance and results, applying visual targets and cues with VR, and also supporting the use of VR in clinical practice as well. Okay. And then our next slide we're going to go over is just some gaps in the literature. Low quality evidence exists in the literature due to small sample sizes, the varying degrees of severity of injury. There's also lack of long-term follow-up with VR intervention. Most research is not within the clinical setting, so therefore determine the feasibility within the clinical setting can be difficult. Since there are various ways to implement VR, immersive, semi-immersive, gaming, along with various types of interventions carried out in the VR setting, it is difficult to establish an appropriate protocol. Overall, more research is needed with use of VR in the brain injury population. Okay, so next we're going to go over a type and example of virtual reality. This is a system that we use in our clinic. It's just an example. This system is a immersive, untethered head-mount display system. And we have a video that can give you the whole idea of what we have. We have sensors on the hands, sensors on the knees. You see that head-mount display. And behind, this is my student, my former student. Behind the student he has sensors on his upper back and lower back as well. So these sensors also help to capture that client's mobility, giving that fully immersive experience as they interact with the activities. And in our next slides, we're going to go over just a few examples of what are kind of games and activities that interventions our clients participate with our system that we use. Okay. So you can see here, he is sitting with the display. And with this activity, we pretty much have a character that's throwing these flying fish out, and he has to reach for that target and try to tap the fish. He's using visual scanning because he has to keep his eyes on the target that's being thrown, working on also coordination of his upper body. He's working on his sitting balance and trunk control. We can also do this in standing, where he'd be working a little more on his standing balance. And the other thing too, he's getting that positive feedback, that positive reinforcement. So every time he hits that fish, he gets a +1, a point. The characters cheer, so he knows he did that correctly. And again, just allowing for that positive feedback to reinforce that skill that he's working on. All right, and then we'll go to our next slide. Okay, this is an example. This is a virtual pinball. So for those who are familiar with pinball, in this game, I have him sitting there utilizing a paddle, which is kind of mimicked in I don't know if you can see it pretty well through the activity, but he has a big long paddle he has to hold in the game. For the clinic, I have him holding a 3-pound bar. So this also adds a little resistance to the activity, in addition to a little proprioceptive awareness to help utilize his upper extremities. He's utilizing that visual scanning component, trying to find that target of where that ball is going. He's using that coordination aspect, trying to hit his targets. Again, this is another one I've done in standing as well to challenge balance. You're getting see that trunk mobility, causing the client to really reach. And same thing, he's also getting that positive feedback. There's sounds, he gets dings, noise. You see the score go up, and he's knowing he's doing a great job keeping that ball in play with the pinball. All right. So with our system that we use, we're able to modify the settings, which is, again, we reinforce is key, because when we're able to modify and change things, we can make our treatment approach more patient-centered and focus on achieving their goals and working on increasing intensity within the games. So this is just an example of some modifications we can make to the pinball game we just showed you. Parameters you can modify the type of device they're holding. So we can either have a long much dowel like he was using an example prior. You can have two rackets. So there's one on each paddle on each hand, and they had to reach, so the hands would be moving on their own. Foot paddles or foot flippers. So then he has to actually use his lower extremities, so we can incorporate the lower extremities as well. The other thing we can do is bias, whether we want to do more left side, do more right, bring more attention to a specific side to help increase that awareness, maybe help with a little more visual scanning, maybe incorporate more use of that one side of the body. We can also modify that ball speed, how fast or slow it's going. And then in addition to the amount of force we need to apply to the system, the paddles they're using. So whether they need to really reach and push, or do they need just a gentle force? And again, modifying those and helps to change that intensity and make it more challenging for the client, helping them to further progress in the activity that they're doing. And again, just focusing on that client-centered approach, making it more specific to that person. And another example I have, this one I like because we could show you in standing. Of course, we want to make sure we're applying appropriate guarding techniques so that we're keeping our clients safe as well. So this activity that we have in our system is like is boxing. So he's pretty much reaching for certain targets. And you can see on the screen as he's reaching and he's hitting that target and he's hitting it with the appropriate force, the target kind of breaks in pieces. So he knows he did a good job. He gets that positive feedback of that he reached that target, he hit it, and he used that appropriate force to reach for that target. And I also have him using 3-pound weights, or I think 1-pound weights in this one, just to kind of also give a little more resistance, challenge the activity a little bit more, increase that awareness where his extremities are. Okay, so we're also working again on that coordination factor, him having hit those targets. Now this is an example of him standing, so we can show how he's working on that standing balance as well. Weight shifting we're getting with this, visual scanning and tracking. And also it's a pretty good endurance one too, because he can almost keep going for, I think this one goes for about like almost 2 minutes of him just constantly reaching for targets. So sometimes some clients break a sweat with this one. Okay. And I'm going to hand it off to Alana. She's going to go over a cognitive activity with the system that we use.
So this video is going to pan up and down. So essentially this client is immersed in a food truck, and on the top right there, as he scanned up, is the person's order. So he is following the visual cue of how to make the sandwich, and then he himself is having to reach up, left, visually scan. And so in this one, we don't have an example of the settings, but we can change how long that he can see that and make it a memory activity. We can make it more complex. There's actually an option where they have to turn on a stove and actually cook items, add condiments, add so many more things. And then when they lift the tray and hand it to the customer will give them feedback with a thumbs up or a thumbs down, or want to take a selfie if they've done it right or wrong. And so we can set all kinds of different parameters in terms of time limits, making it a memory activity, using more right-left bias, and so on. So there's a lot of really good cognitive and visual components that we could add here. We don't have videos of some other cognitive interventions, but they range from doing like stamp calculations in mathematics to ADL sequencing cards to planting a garden and matching patterns. So there's lots of different options. So the last component of our presentation before we get to the questions will be to just review a case study that we have done and experienced ourselves. So a brief history is that the client is a 57-year-old female who sustained a brain injury as a pedestrian struck by a vehicle at the age of 12. So this is someone who's been injured for a very long time. The current status includes left spastic hemiplegia, significant cognitive deficits, motor planning impairments, and essentially requires assistance for all functional activities at this time. Able to perform bed mobility with standby assistance, ambulatory transfers with a rolling walker with contact guard assistance, ambulates up to 30 feet with a left ankle foot orthotic and rolling walker with contact guard. And that 30 feet requires extensive motivation from a therapist. Left shoulder and bicep pain. And then cognitively has significant impairments in attention, memory, executive functioning, and you could imagine someone who's been injured this long, there's occasionally this limited participation in PT or OT due to fatigue and internal external distractibility and just, overall motivation, right? So our client's goals were and are to improve her current ability level in cognitive therapy for improved participation in structured tasks, to improve mobility, endurance, and safety during transfers, to improve functional awareness of maladaptive behaviors, and to increase independence and safety in ADL, IADL, and other daily occupations. And you can see a lot of these goals are written from an interdisciplinary approach. I'm going to turn it back over to Christy.
All right, so I'm going to go over just about some of the interventions, how we carried this out with her, and some findings that we noticed. Our client participated in 15 to 20 minutes of seated immersive virtual reality use. She averaged about 2 sessions per week for about 8 weeks. So our feedback is going to look over that 8-week progression. Activities that she participated in incorporated reaching skills, trunk mobility, lower extremity mobility, and cognitive tasks. I'm going to go over just a few examples of what we did so you can kind of just see how we helped carry out those interventions. There was one activity that she was sitting and on the screen was pretty much a bunch of birds perched on a little branch, and there was a bunch of nests, and what she had to do was reach for the bird and match the color of the bird to the appropriate ribbon on the nest. So that was causing her to have to work on that functional reaching for that target, as well as scan, look, and use that cognitive piece of matching the colors together to reach and move that bird to the matching nest. It was great to see because when she did this activity, I pretty much was amazed by how far she can actually reach versus what I make her do outside the VR. Another great thing is during those sessions, she would get that positive feedback. Once all the birds were matched in the same nest, those birds would be singing, and she would realize and recognize that she did it correctly, and she achieved that activity. Another one that I had her participate with was a sitting reaching activity that she was reaching to different targets that were coming at her, and the targets came to the beat of a song. So she had a little more of an auditory feedback, hearing that beat, hearing that rhythm, and having to reach her arms out to those targets. And every time she hit that target would open up and just kind of break into pieces. So she knew, again, getting that positive feedback that she did a good job. This activity also incorporated the lower extremities as well, so she'd have to kick out to the targets. So it was really great to see her work on that and also address that sustained participation with those tasks as well. Okay. And just even after just those 8 weeks of that VR intervention, she demonstrated sustained attention throughout the sessions of 15 to 20 minutes of strictly the VR use, with minimal to no cueing for participation. I also measured her modified functional reach, so sitting on a table or her chair and seeing how far she could reach out. And after those 8 weeks of just the VR use, she demonstrated improved left upper extremity functional reach by 4 inches and her right upper extremity functional reach by 1 inch. And this is just after 8 weeks. She demonstrated improved trunk mobility. Another big thing was that improved participation and motivation. Sometimes she would come into therapy feeling tired, not wanting to do anything. I don't want to walk. I said, how about VR? You want to do some virtual reality? And she'd be jumping all over, ready to get into it. So, and again, just not only just a 5-minute activity, but for her to actually sustain constant mobility and participation for 15 to 20 minutes, I just get so much out of her during those sessions. And she really enjoyed them too. The other thing we found that is when she participated with the VR, she sometimes would come in, maybe her back aches her, or she has some shoulder pain. But that seemed to not be a big barrier when she was in the VR. She was in that virtual world where almost just everything else that she was interacting with kind of took that pain away. And so she was able to actually participate and use that left arm that she said hurt her. So I found that it was definitely a motivational piece, but also it was able to help another alternative to treatment to help engage her a little bit more and get her to push herself a little bit more and increase that intensity compared to some of the traditional stuff we did in PT that maybe she just was too tired to do, too fatigued to do, or uninterested is also the other thing. And just with our system, just some other interventions that our type of VR system uses. There's a shower simulation, so the client will pretty much have to participate in sequencing of showering appropriately, reaching for the shampoo or soap, rubbing their hands together. It's all through like an avatar on the screen. Color by number, so it's a nice fun leisure activity for those that like art, and then they also have to match the color to the number to get those cognitive skills. And we could also modify where that board is and what they're reaching for, so we can cause them to reach a little bit more, use a little more of that trunk mobility, and maybe do a little bit in standing as well. Another activity our VR system uses is it's kind of like a hide and seek. So you have characters that are pretty much hidden in the environment, and they have to locate with their eyes on the target and try to find all the characters hidden within the environment background. And they get that positive feedback when they land on that target. The character would do a dance that they found them, and they score points. So just seeing how many, and they'd be like, oh, I got all 15, and making sure they found them all, as they get that feedback that they did a good job. So, and again, this is just an example of the system that we had. Nothing really that it's just the only type of VR systems. There's so many different types out there, but just to give an example of how VR can be incorporated with rehabilitation interventions too. And the most important thing that we found with some of the VR interventions we use is the client feedback. They enjoy it. They love it. And this is just some feedback we have from some of our clients. This is cool. I can work on my visual scanning. This is more fun than my PT exercises. I was like, all right, get them to do something. I would rather do this than my other exercises. I can use my left side. So clients, when you see how happy they are, they're laughing, they're enjoying it, it's just bringing something more to their everyday treatment intervention, giving them something different to do, especially clients that we found that are a little more or way more into those chronic stages of brain injury, that we found something new that they can just be challenged with and enjoy too. So, when you get that, do something with that client feedback and you make them smile and laugh and enjoy what they're doing, and seeing it's benefiting them is very rewarding as well too. And then thank you guys so much for letting Alana and I speak, and we can get to some questions in the chat as well.
Yeah, so thank you so much for that most informative presentation. I do see some questions in the chat, so I'll just go ahead and go through some of them. So someone said, how can I find a VR provider, and does Medicare ever cover VR therapy?
So I would say like for us, sometimes there's a lot. There's so many vendors out there, and I would definitely like usually you can meet with them and they can show the types of equipment they have and see if it's suitable for your setting. I know for physical therapy and a lot of the physical therapy magazines, they do have advertisements for certain types of VR services. I think the challenging thing is finding something that works for your setting and knowing the difference between like the immersive, which is again those head mount displays, the untethered cords, or something a little more semi-immersive, which can be a little more the like the treadmill ones or the ones that are in a big room.
And I think if you're a client looking for someone who's providing VR, it's usually like advertised on a website, but there, as far as we know, there's no like comprehensive list of what clinics or settings have them. It may be a question that you would have to call and ask about. Yeah.
Thank you. And then someone asked, based upon your research review and your own experiences working with people with brain injuries, if someone who is nonverbal with an anoxic brain injury and no ability to move, could using VR help that person gain those skills back with the help of a PT moving their arms and legs for that person?
I think that's like a really specific question. And without knowing more about the case, it's hard to answer. So I don't think we can give like an absolute yes or no. Generally, though, virtual reality is reliant on like active participation. So and there's certain, you might need physician orders and things like that. It's not to say it wouldn't be worth a try, but I'm not sure that we could give a really concrete answer of like, yes, this would help. No, it wouldn't. There's, I think, a lot of variables at play. I'm not trying to evade the question. I think it's maybe something that would be worth a discussion with the physician and the treating clinicians and things like that.
Absolutely. Yeah, that makes total sense. And then someone asked what the name is of the system that you use.
So our system actually just got discontinued. So it's not actually beneficial for us to give it because it is no longer available. With that said, we are starting to research new ones. And if someone, is interested in finding out what our research shows, they can certainly give us their contact information. And as we go down that line, we can certainly share anything that we're finding of value. But unfortunately, our system is no longer going to be produced or available. So we're able to use it, but just until kind of filling a gap, I guess, right, Christy?
Great. Thank you both. And then someone asked, does the clinician see the screen with the immersive one that goes on the eyes? Does the clinician see the screen as well?
Yeah, so well, for our system, it has like a small tablet, so we're able to see what the client sees. I tell you, it looks way different when you have the head-mounted display on because it's so immersive, but definitely we can see. So we're able to kind of give a little verbal cueing feedback if we find that we need to adjust those settings, that we can look and see what the client's doing to provide and change that intensity as well.
So
Okay,
in those
great.
videos that we showed side by side, one was the clinician view and one was the client. So they weren't always synced perfectly, but so the view that you could see of what the client was trying to hit or the pinball, that's and our system is on a tablet that we're able to see. And most systems have some sort of clinician access.
Okay, great. And then someone asked, how common are issues with vestibular tolerance when engaging with VR? So I guess those dizziness issues, those side effects.
Yeah, I don't know if I can put a like number to it based on the research. It's out there. Um, some from my experience, I haven't had anyone really encounter anything, but I think the biggest thing is knowing an individual that is vestibular intolerant that might need to be either trialed in it or educated before trying it. And I think that'd be more at the clinician's discretion on how comfortable they feel the client would be appropriate for that. But I think just knowing that could be a side effect of VR treatment and being aware of clients that are vestibular sensitive, that we just want to be cautious when using especially the immersive systems.
Okay, great. And then along similar lines, someone asked if there are any risks for residents with epilepsy.
So in the documentation, it doesn't, that we found, Christy, correct me if I'm wrong, explicitly identify it. Our personal practice has been clients with any sort of recent seizure. We have asked for physician clearance and orders for it. It may also be dependent on the system. So you could see our system is sort of a cartoon world, and some of them were pretty slow moving in comparison to maybe the boxing one was more dynamic. So we may make modifications based on what we think the visual stimuli is, but in general, epilepsy, seizure disorders, we are asking the physician about from their perspective what they think, and always sort of erring on the side of caution.
Okay, great. Sounds good. And then someone asked if there's any commercially available VR systems that might be helpful in this way.
That is a great question. None that we've personally used, but there are some commercially available ones that people use at home. I've had friends who've been in them and they're supposed to, like walk off the edge of something, and they feel much more real. And when we were selecting our system, we actually preferred that the virtual world was sort of cartoonish. Sometimes our clients with brain injuries, and this is not all by any means, but sometimes, orientation can be a concern, or if there's any psychiatric concerns about delusions or things like that, we really wanted it to feel not so real. So some of those more commercially available ones are very realistic. So like there's like the Oculus, things like that that are more available to the public. But we haven't actually trialed any of them, and the research is more geared toward the more therapy specific ones, but that's not to say they're not out there. But again, just all the factors that go into play. So, personally, we like the fact that our world is less realistic than some of the other ones out there, but that's, always a decision that people can make.
Okay, great. Yeah, that's a great point. That's not something I thought of, the fact that one may be more realistic than the other and what effects that might have. So that's a great point.
Right. And for the right person, that could be really, really relevant. And for some people, it might not. So, that was a decision for us. But again, that's not necessarily the same decision for all clinicians or all individuals with brain injuries.
Right. Okay, great. And then someone asked, they asked, would we find VR services at providers other than PT? And even going, looking forward into the future, are there any promising modalities or therapies other than PT that might be able to use VR?
So I can say I'm an OT, so I use it. And is new research coming out about the efficacy for speech therapy. There's also, outside of just our clinic practice, there is new and emerging research on the use for a variety of psychological things. So depression, as well as other physical conditions like pain management. And then I referenced at the beginning, there's a whole new system that they're doing research on now, just targeting like empathy training and emotional things like that. So I think the research over the next several years will really kind of explode. But along like the therapeutic disciplines, I think there is uses and clinical indications for all of them. Christy, I think I cut you off.
Okay, great. Thanks. Um, and let's see. Someone asked about vision issues. They said that they struggle with some vision issues. So does it adjust to things like that, or are there different customizations that you can make?
So our headset, depending on the client, some prefer to actually wear their glasses with it too, so there's more of that. And then the system that we have also allows to a little bit of visual accommodation. You're able to kind of adjust the screen to help improve a little clarity, but it's not anything that's so significant. So if a client does say it's a little blurry, needs to click to adjust it a little bit, they can.
And in terms of treatment, if it's things like visual inattention or, neglect, things like that, it's great for that. We use it all the time. So we can, in those settings, skew things to be present more on the left side than the right side, and really be via our feedback, cue the client, turn your head more and more and more. You haven't found it yet. And so it's really great at actually treating visual issues.
Wow, that's great. And someone else asked, is there any training that's required for clinicians to be able to effectively use these in treatment? Anything that you know of?
I would say the biggest thing is that you're comfortable and very familiar with your equipment, know the limitations, know your clients, and I think that it does depend on certain devices and certain types of settings of how you're using the VR. That you just want to make sure it's clinically appropriate. So just knowing that equipment and also knowing your clinical judgment on keeping our clients safe as well. So one thing, like something I would ask is, from the VR company, just to say, have they found anything that they find has been a frequent problem with certain people using it? Or if they, based on their studies and research, is there anything that seems to be coming up that they recommend we don't use it for, such as like our questions were like pacemakers or shunts, and things like that we try to stay away from, just since there's like devices in there.
Definitely makes sense. Okay, great. Let's see. Someone asked, is there any assessment available to screen in advance for suitability for persons with vestibular disease?
Specific for VR, not that I know of.
Okay, great. See what else. Make sure I'm not missing any. Someone else had asked about Medicare, if it's covered by Medicare. Let's see.
I don't know that we know the exact answer about that. I think it may depend on how it's coded and justified.
Okay. Sounds good. Let's see. It looks like that's
I would
what's
just
that?
add some of these questions we maybe can't answer yet because the research is still so limited and up and coming. And, I think that hopefully over the next 5-10 years, hopefully sooner, a lot of these questions might get more teased out. But I think it's still, and I think that the systems are so varied and so unique that anything really standardized, the literature showed us, is just really difficult right now, but hopefully that is coming.
Absolutely, for sure. Let's see. So it looks like those are all the questions that I see. Some great questions, some great feedback in there. So thank you everyone for coming. Thank you both for sharing your expertise with us today. And if someone's question was not answered today, you can email me at kmyers, KMYERS @BIANJ.org. I'll also put that in the chat. And I will try to have our presenters answer it. So one final reminder to please complete the post-webinar survey. The link can be found in the chat, and you'll automatically receive a certificate of attendance via email once you complete that survey. So thank you again for attending, for everyone's thoughtful questions and comments, and we hope to see you at the December 18th webinar about disorders of consciousness. This concludes today's webinar. So thank you so much, Alana and Christy. We truly appreciate it. Really informative presentation. So thank you for coming in today.
Thank you, everyone.